Scoliosis surgery. It is a medical condition in which a person's spine is curved from side to side. Although it is a complex three-dimensional deformity, on an X-ray viewed from the rear, the spine of an individual with scoliosis can resemble an S or A, rather than a straight line. The scoliosis cause. An estimated 65% of scoliosis causes are idiopathic, about 15% are congenital, and about 10% are secondary to a neuromuscular disease. The scoliosis surgery is usually recommended by orthopedists for curves with a high likelihood of progression, curves that will be cosmetically unacceptable as an adult, curves in patients with spina bifida and cerebral palsy that interfere with sitting and curves that affect physiological functions such as breathing. Surgery for scoliosis is performed by a surgeon specialized in spine surgery. For various reasons, it is usually impossible to completely straighten a scoliotic spine, but in most cases, significant corrections are achieved. Are two types of procedure. Anterior fusion, the surgical approach is through an incision at the side of the chest wall. Posterior fusion, the surgical approach is through an incision on the back and involves the use of metal instrumentation to correct the curve. Spinal fusion is the most widely performed surgery for scoliosis. In this procedure, bone, either harvested from elsewhere in the body, allograft, or from a donor allograft, is grafted to the vertebrae so when they heal, they form one solid bone mass and the vertebral column becomes rigid. This prevents worsening of the curve at the expense of some spinal movement. Modern spinal systems are attempting to address sagittal imbalance and rotational defect unresolved by the Harrington rod system. They involve a combination of rods, screws, hooks, and wires fixing the spine, and can apply stronger, safer forces to the spine than the Harrington rod. Prognosis. Generally, the prognosis of scoliosis depends on the likelihood of progression. The general rules of progression are larger curves carry a higher risk of progression than smaller curves. A thoracic and double primary curve carry a higher risk of progression than single lumbar or thoracolumbar curve. In addition, patients not having yet reached skeletal maturity have a higher likelihood of progression. For example, if the patient has not yet completed the balancing road sport, females have a greater risk of progression as well.